Good morning, everybody. Thank you for having me here again this year. I was asked to speak about late relapse, and I think Raphael's very nicely covered some of the issues with early relapse. These are my disclosures. He pointed out in his talk that our recommendation is to use your best drugs early and to use as many of them as possible. And there is no doubt in my mind that we are curing a higher percentage of myeloma patients today, if not a true cure, at least a functional cure in many, particularly those with low-risk cytogenetics. However, it does lead us with a problem, as Raphael pointed out, at the end of the game for those who do not get cured by therapy, which is still probably 75% of our patients, who have then been exposed early to multiple rounds of proteasome inhibitors, multiple rounds of immune-modulating drugs, increasingly use of daratumumab, and we now call these patients triple-class refractory or penta-exposed, if you want to name another name, where all 5 of the major drugs that we use have already been used multiple times. And we know from a look at our own data at Mayo Clinic that the expected survival of these patients is dismal, somewhere in the range of 3 to 6 months, depending on which analysis you look at. Now, one can go back and recycle other drugs. There's some molecular evidence that that can be helpful, that previously responsive clones can reemerge over time. One can use cytotoxic chemotherapy, such as DPACE. However, that is a bridge, usually will only be very temporary in its activity, and is usually used as a bridge to something else, such as a clinical trial or a transplant. And as of today, there are no new approved drugs with established clinical activity in this group of heavily refractory patients. And what I'd like to do now is to talk you through what's coming, which I think will very quickly change that equation. So let's start with small molecules, and Raphael has kindly already covered this in part, and I won't dwell on it too long. But again, it comes back to this issue of different classes of myeloma behaving differently, such as the T414 group, which has a very poor prognosis and responds very well to proteasome inhibitor therapy, and then this T1114 group that Raphael has just discussed, which seems to be exquisitely sensitive to venetoclax. This was the original phase 2 clinical trial from Shaji Kumar at Mayo Clinic in Rochester, showing an overall response rate of 40% in the T1114 population. But as Raphael just showed you, my own personal experience